much for that wonderful introduction. Thank you. And I'll ask the requisite questions. Can you see my slide and hear me, please?
We can see your slides and your voice is quite good.
Okay. Thank you. Thank you. Thank you very much, Dr. Ashutosh Mishra, for this very, very kind invitation. And it's a pleasure to be here. And it was a wonderful talk that you listened to about the hypoglycemia and the problem of hypoglycemia and diabetes. I'm here to talk about the role of low carbohydrate diets and its use in diabetes and in the management of insulin resistance. And I want to spend the next sort of 15-20 minutes really talking about these things. What do we mean by low carb? I find that at least initially when I started off thinking about low carb and prescribing low carb diets for my patients, and even nowadays, there is a lot of confusion and myths surrounding the term. And I think a lot of the hesitancy in trying to accept low carb becomes because of this sort of misunderstanding of what we understand, what we mean by low carb. And I want to share some of my personal experiences with low carb. What does the published data show? And a little bit about biochemistry, why it works very well, not only for controlling the blood sugars, but also for weight reduction and also for avoiding hypoglycemia, actually, interestingly. What are the myths surrounding it and what are some of the don'ts? Where are the places where we have to be careful about prescribing low carb? So the first thing is, what does low carb mean? And in our usual South Indian diet, and I'm sure that this is true of all Indian diets, most of our Indian diets, so-called good diets, we land up consuming about 400 to 500 grams of carbohydrate. So most of our diets, about 80% of our diet is carbohydrate, which works out to quite a substantial amount of carbohydrates in our daily diet. And when we say low carb, what we're talking about is roughly about 130 grams of carb. And I'll come back to why this is considered a minimum amount of carbohydrate we need to consume per day. What do we mean by 130 grams of carbs? So just to give some idea about what is the normal carb content in most of the foods we eat, one idli is supposed to contain anywhere from 15 to 20 grams of carbohydrate. One chapati has about 20 grams of carbohydrate. 1 cup of cooked rice, whether it be white rice or brown rice or millet rice, whatever be the type of rice, roughly has about 40 grams of carbohydrate. This is about a small cup. When I say small cup, roughly about 5 tablespoons of cooked rice would be about 40 grams of carbohydrate. So for example, if you take a relatively sparse meal like this, which is just 2 idlis, half a cup of sambar and maybe 1 apple, this itself is about 60 grams of carbohydrate. And let's take another example. You have 1 small bakri here, 1 small cup of rice, a boiled egg, and a little bit of leafy vegetables. Even if we leave out the kheer here, even then this works out about 70 grams of carbohydrate. So most of our diets have a lot of carbohydrate inbuilt into it. And like I said, there is a lot of confusion and a lot of hesitancy in accepting or trying to incorporate low carbohydrate diet in our practices because we think immediately of keto or high fat or Atkins, and there is a lot of confusion. So I want to talk a little bit about what the terminologies mean. Intermittent fasting, of course, is something which is very popular among some people, and it's not a specific pattern. All it does is it is an eating pattern which cycles between periods of voluntary fasting and voluntary eating. And it does not say anything about the type of food to eat, but only it says that eat in this interval. So eat in an 8-hour interval, say between 11 a.m. and 6 p.m. and do not eat for the remaining 12 to 14 hours. And some people find this easy to follow. But it does not really fall under the category of a low carb diet unless you've also reduced the quantity or the intake of carbohydrates. If we compare it with the keto diet, the so-called keto diet, the main difference is that in a keto diet, the principle being that you reduce the intake of carbohydrate to less than 20 grams a day, which is when our body turns to making significant amount of ketones in the blood and induces ketosis. In this type of diet, typically we would have only about 5% of the intake from carbohydrate, 70% from fat, and about 25% from protein. This is with comparison to a regular low carb diet where we restrict carbohydrate to about 20% of the total intake, and the remaining 80% is about evenly divided between fat and protein. And when we come to an LCHF, which is a variation of the keto diet, low carb, high fat, the fat content is much more. It may go up to even about 75 to 80%. And the protein also comes down, and carbohydrate, therefore, is forced down to very low levels of intake. And if you compare it with, say, something called the paleo diet, the main difference between, say, a keto and a paleo diet and a low carb diet is that in a paleo diet, dairy is prohibited. And in general, it tends to be higher carbohydrate because they allow you to take in things like fruits and honey. And then the principle being that you're going to take in foods which are relatively less processed. You take in foods which are in the more raw form. So depending on the type of paleo diet people are consuming, they may or may not be in a lower carbohydrate zone. And Atkins, of course, is relatively higher protein. In general, this is not followed to a great extent, but it depends on what, there are various phases in this Atkins diet, but in general, the emphasis is on increasing the protein intake. Ultimately, the destination is the same. If you sort of compare all of these diets, you will find that all of them, because they're reducing the carbohydrate and having relatively more protein or fat or fiber, ultimately they all induce satiety and force you to eat less. So in general, the caloric intake should be less in most of these diets, and the carbohydrate content definitely comes down because of the emphasis on more protein and more fat. So the end destination is the same. For the rest of my talk, I'm only going to be talking about a pure, relatively pure low carb diet, and I will explain the type of diet advice that we give. But in our type of a low carb diet, we are certainly not recommending high fat. We are not recommending meat. In our country, which is predominantly vegetarians, you can reduce the intake of carbohydrate consistently in a sustainable manner to about 100 grams or 120 grams of carbohydrate a day and still achieve significant benefit in terms of blood sugar lowering. And like I said, we sort of for about 3 years, we've been working on helping people with lowering carbohydrate intake. In fact, I had presented an abstract, the feasibility and effectiveness of a low carbohydrate diet in a traditionally high carbohydrate intake population. So when I had first started working on this, I was not sure if we could come up with a low enough carbohydrate intake for vegetarians, and we easily can, and people are very happy to adhere to it. We make up for lowering carbohydrate by having a lot more fiber in the diet and a lot more vegetable protein. So lots of dals and pulses to some extent. But dals and pulses and legumes also contain carbohydrates, so we cannot overdo these things if we want to maintain a relatively lower carbohydrate count. So I just want to present 3 clinical scenarios from my own patients. I just want to share, and then we'll talk about what the data shows. So this is a 48-year-old male. He's actually a physician. He underwent a PTCA at the age of 42, and has after the PTCA, he actually went on to develop diabetes. He's currently on metformin. He's on statins. His mother has diabetes. He's an extremely healthy person. He runs regularly 5 days a week, and he monitored his sugars at home, and this is what was happening. He's 172 centimeters. He weighs 85 kilos, so slightly overweight. And these were his sugars. What he thought was fairly under control. So he was just continuing with the metformin 500. What had happened was that he had neglected to do his blood test the whole of 2019. In the middle of the lockdown, he started getting some pricking of his feet and pricking of his toes. So he went to check his HbA1c, and he got this. His fasting was 242. His HbA1c was 11.8, and he got a shock, as you can imagine, because this was his previous lab report. This was what I had changed him to. I put him on glyphosate 1 gram after dinner and a Lina-Empa combination 1 in the morning. And this is what I had prescribed: a no sugar, 70 to 100 gram carbohydrate diet, and to continue with this exercise. And about 100 grams of carbohydrate would work out to a diet like this. And you can see it's a fairly, I would say not a very, for Indians, this is a manageable diet. So they would, for example, one of the things we advise is either a dal idli or a moong chila, very, very minimal cooked rice. So about 4 to 5 tablespoons. This is what takes some getting used to. And then you can do some cauliflower saute or paneer saute or a tofu saute for dinner if you're a pure vegetarian, and this person was a pure vegetarian. And this is what happened to his blood sugars. Within a month, it had dropped to 8.8. His fasting had come drastically down, 96. Of course, he was on this combination at that point in time. He continued to do well. And talking about time and range and talking about hypoglycemia, one of the things I wanted to point out was his AGP, his glucose monitoring chart, his continuous glucose monitoring chart. And you can see one of the main advantages of a low carb diet is that you avoid the extreme peaks and the lows. So you do not see the previous talk, Dr. Manish had shared, the hypers and the hypos, and this does not happen. This does not happen if you put them on this low carb diet, and you can see this extremely smooth blood sugar control that results because of that. And this was this person's, again, the glucose monitoring chart. Sometime in October, when his HbA1c had come down to 6.6, we actually stopped Empalina, and I just kept him on metformin 850 once a day after dinner daily. Now his HbA1c is actually lower than this. This is from January. I apologize for the quality of the picture. He'd come down to 6.3, and now he's actually, sometime in March, he's down to around 6.1, and he's just continuing with the metformin. And the plan would be to keep him on some minimal OHA. Still, he's achieved a good HbA1c of around 5.8. Depending on how much he's able to maintain a good low carb diet. If he's not able to maintain such a strict diet in the long term, we may just need to keep him on the metformin, but maintain some reasonable aspect of that long term, of the low carb long term. So this was the first case. Second is Mrs. SS. She's 62 years old, and she's 155 centimeters, 61 kilos. And she is both hypothyroid, and she's had diabetes since 2010. And these were her medications at the start of the lockdown, really. She was on Sita, metformin, and 5,500 in the morning, 50,000 in the night. And this was her HbA1c. Now, of her own accord, and these were her values at the start of the lockdown. Of her own accord, and we spoke about the low carb diet, and she wanted to try it. And these were also something of concern in her. Her AST, ALT were very elevated. We did do an ultrasound abdomen. They had been elevated ever since 2019, if I remember right. We did do an ultrasound abdomen, and the ultrasound abdomen just showed a grade 2 fatty liver. So this was where we were. And all of her other parameters were normal. Her eyes were fine. Her kidneys were fine. Everything else was fine. She went on to a low carb diet, but she also decided to do intermittent fasting. So she started the fast around 6:30, and she ended the next day by 10:30, 11. Initially, when she was taking all the medications, she did have excessive hunger around 9:30. Then we reduced her tablets, step by step. In the evening dinner, she mostly did not consume any carbs. She did sweat. She did have palpitations. She had a history of UTI, which is one of the reasons we could not think about using, it was a relatively complicated UTI, so I did not want to initiate SGLT2 inhibitors. And she was walking regularly. However, she did remarkably well with continuing, and ultimately at some point in time, we actually stopped her medicines. I think in August, when she had come down to this, you can see how much she'd done well. She is still continuing a combination of low carb with the intermittent fasting. She's lost about 10 kilos of weight. You can see she is now technically non-diabetic. And of course, the other thing that happens consistently when people lose weight is that their levothyroxine requirement comes down. So she came down from 100 micrograms to 75 micrograms, and her liver function test settled down remarkably. And these are her most recent liver function tests. And you can see this was in March, and this was her most recent, I think this was in January. It settled down very well, and all of her other parameters, her lipid profile, her, and I'll talk a little bit about what happens with the LDL, but all of her other parameters settled down very well. She feels very well, and she's actually been off all of her diabetes medicine. She's only taking her thyroid medications currently. And the final case is a Mrs. SR, 66. I saw her just about a month ago. She presented because of complaints of nocturia. She's had diabetes for 15 years, and she's also hypertensive and hypothyroid. And she had some abdominal discomfort, and she had multiple investigations done. She had endoscopy, ultrasound, and blood and urine test, and everything was normal. And finally, it was put down to intolerance to metformin. and she could not tolerate statins. She had significant myalgias and joint pain. When I saw her, she was on levothyroxine, she was on glimepiride, and she was on deglutec, and she'd been on insulin for about a year. Again, she's just started on a low carbohydrate diet. She's an extremely motivated person, exercising regularly. These were her reports when I saw her. You can see that there is a big discrepancy between what fasting LPP in the morning with a HbA1c of 10.5. So I encouraged her to check her blood sugars all through the day, trying to see where she was peaking. And we put her on a low carbohydrate diet. And I just put up this slide to show the rapidity with which the sugar levels start coming down. So you can see that within about a week, her fasting blood sugar is dropped to 101. In fact, I reduced, this is something we see again and again. We reduced her deglutec dose. She was taking 34. I reduced it to 25 actually, and we've reduced it further now. And you can see that these are her sugar values. Only her post-dinner was not really settling down, and we discussed that, but her other values settled down very well. And she's again a vegetarian, and we just reduced the carb content in her diet. So I present these three cases to say that it is eminently doable in our population to have them reduce their intake of carbohydrate and help to control their blood sugars and help to reduce their diabetes medications. And I think one of the sort of stupendous examples of this, and I'm sure Dr. Manish is familiar with this, is the direct trial, which came out from Newcastle. Newcastle is one of the places I trained at. And what they did in this was they took people with type 2 diabetes, aged between 20 to 65, and they put them on, and they wanted to see if diabetes could be remitted if they put them on a very low carb, very low calorie initially diet and make them lose weight. And this was the demographics. You can see that 60% of them were males, and this was the average BMI. So very high BMI, 35. This was the average age, 55, and this was the average duration of diabetes, 3 years. So not very long-standing diabetes. And what they did was, for the first 3 months, they put them on an 830 kilocalorie, very low calorie diet. But this was by no means a low carb, because 61% was still carbohydrate. In the first 3 months after the weight reduction, they went on to a stepped food reintroduction, where they were given a 400 kilocalorie meal every 2 to 3 weeks. And then they entered what is called the weight loss maintenance phase. And what this showed was at the end of 1 year, about 45% of people who were in the intervention group achieved diabetes remission, in the sense that they were off all of their medications and maintaining good HbA1cs without the need for any medication, with a relatively normal diet. They were still, they were not on the 830 calories. They were eating somewhere around 1,500 calories per day, but they were still maintaining their diabetes remission at the end of 1 year. And what this study pointed out was that the extent of diabetes remission, the number of people who had their diabetes remitted, was directly proportional to the weight reduction. So when you lost more weight, the higher the chances of going into diabetes remission. However, I do want to point out again that this may not be suitable for all people with diabetes. For example, when the third patient I presented who'd had diabetes for 15 years, who are already on insulin, this is not a person who, unless you're going to do it under very close supervision, it's very difficult to take this person and put them on an 830 calorie diet for 3 months, get them to lose weight, and then slowly reintroduce carbohydrate. We can do that as part of a trial, but it's a little bit difficult to do that in real life. So what we can do is just reduce the intake of carbohydrate, and that works very well at controlling the blood sugars. And in fact, this was a meta-analysis looking at all of the studies that have looked at reversing type 2 diabetes, and this was published a couple of years ago now. And this graph basically summarizes the findings of the trial. So the blue chart is the sleeve gastrectomy, the red bar is the bypass, and then you have the low calorie, LCD is the green bar, low calorie diet, and this purple line right at the bottom is the low carbohydrate diet. So they looked at all of the studies that looked at these means of achieving diabetes remission. And you can see that the low carb diet, though it did not cause much weight reduction, did have a significant impact in HbA1c reduction. The reason for the HbA1c going up after 1 year is because most of these diets stopped the low carb component of it after 1 year. And you need to maintain that low carb component to maintain the HbA1c reduction. So this is very important to keep in mind, because a lot of the confusion, if you go back and look at the studies and they say, oh, low carb doesn't work, it is because the low carb component of it was not maintained, and they did not do it low carb enough. The study did address potential complications of significant carb restriction, and these were the sort of the comments in the study. In general, the low carb trials are safe and well tolerated, although long-term hard outcome data is lacking and should be a focus of future research, and that's absolutely true. We do not have people who have remained on a good, like 100-gram low carb for 5 years or 10 years and found out what happened to their complications. All we have is short-term trials. They do it for 6 months, 1 year, and that's it. If they are on a very, very low carb diet with relatively high protein, they will have a transient rise in uric acid. When I say very low carb, again, these are all studies where they restrict the carbohydrate to less than 20 to 40 grams of carbohydrate a day, which is not something that I personally do. The blood urea nitrogen again tends to increase, particularly if the protein intake is very high, particularly animal protein intake. Again, this is not something we generally do in our predominantly vegetarian population. And there is no change in bone density. I think this is very important. So the bone mineral density does not change in spite of significant weight reduction, at least in the keto diet. One thing we do need to look out for with any type of dietary advice that we give is micronutrient deficiency. So we need to make sure that they are adequately replaced with other vitamins, say your vitamin B12 or your iron. But in general, a well-balanced diet with the help of a nutritionist, if you just reduce the carbohydrate, but they have enough of protein and fat, in general, I've not faced any problem with micronutrient deficiency. What about the lipids? There is always a concern that a low carb means either high fat or a low carb leads to increased cholesterol. Most studies find no change or an improvement in the LDL cholesterol. Some people do have an increase in the LDL cholesterol, and of the patients that I presented, one lady did go from a 60 LDL to a 90 LDL. But all the studies have consistently shown that when you have reduction in weight and when you have a reduction in the carbohydrate intake, your markers of inflammation come down, your CRP comes down, the ESR comes down, your small dense LDL comes down, ApoB lipoprotein comes down, and non-HDL also does not change. So if we find that the LDL cholesterol is going up in someone who's otherwise doing well, in other words, the triglyceride has comes down, the HDL has gone up, the CRP has come down. If all other markers of inflammation are getting better, only the LDL is going up, we should think about measuring other potentially atherogenic lipoproteins like ApoB to make sure that we are not adversely impacting the lipid profile. But I want to reiterate that a good low carb diet does not, for the most part, adversely impact the lipid profile, provided we are not overdoing the fat component in their diet. And again, this is from that 48-year-old male with a history of PTCA. I wanted to point out, of course, you know, I was concerned, he was concerned, he'd had a PTCA, we did not want his lipids to go up, and he was on a statin, and you can see that once the sugars came down, his triglyceride remarkably dropped. His insulin sensitivity had improved so much, and his LDL also actually reduced in this particular situation. So he did very well, and there was no concern about increase in LDL in this one person. So why does lowering carb work so well? I think we're all familiar with the fact that insulin is the anabolic hormone, fat storing hormone. Every time you eat carbohydrate, your body spikes by making insulin, which is why we tend to gain weight when we eat too much of carbohydrate. If you look at insulin action from a whole body perspective, insulin has what is called a fat sparing effect. What does that mean? It drives most cells to preferentially oxidize carbohydrate instead of using up fatty acids or stored fat for energy. Insulin's action is that insulin wants our body to store energy. So every time we give it carbohydrate, it will tell the body, okay, use the carbohydrate, don't use up your stored fat. The more important effect of insulin is also to inhibit glucagon in alpha cells and opposing the action of glucagon in the liver. So overall, long term, if we make our body make less insulin, which works more effectively, this leads to consumption, utilize, and we give it less carbohydrate. We force the body to utilize fat as a source of energy, which causes weight reduction and reestablishes insulin sensitivity. So when we have lower blood sugar spikes, you have less insulin spikes, you have less fat storage and less inflammation in our body. Now, this is a hypothetical graph that I've put up, and this is what I use to explain to patients. This is the insulin response to different foods. This is with simple carbohydrates. So for example, you have a fast drink or you have a spoon of sugar, your insulin levels will spike up to say a factor of 100. If you've taken complex carbs, so this is where I'm talking about things like hand pounded rice or millets or say, rolled oats, things that take longer to digest, they still produce a significant insulin response. Vegetable proteins also produce a good amount of insulin response. So this would be your dals and your pulses and your legumes, certainly better than your simple carbs or your complex carbs, but still there. Animal proteins, things like egg and fish and chicken, less of a insulin response. And fats, interestingly, very little to no insulin response. So if you let's say just have a spoon of butter or a spoon of ghee, your body will not make any insulin to metabolize that. So this is the insulin response to different foods. So if we target the diet or change the diet in such a way that we are having much more of vegetable proteins and we do not neglect to take in fat, if we predominantly eat this and a lot of fiber, over a period of time, the insulin response will settle down and cause much better sugar control. So the insulin response, you need to have less spike. One way of doing that is obviously by eating less, but also eating less often. So eating the 6 times a day and every time having your body make insulin spikes is not a good idea. Eating twice a day or thrice a day or eating according to your hunger is a good fact. Eat more complex carbohydrate, yes, but eat less amount of it. Eat more protein and certainly do not be afraid of fat in the diet. Now, there are some common misconceptions regarding low carb diets. The first being that we cannot live without carbs, or that it may lead to ketoacidosis, or that it encourages high fat intake, which can increase heart attacks, or that it can cause renal failure. And I want to address this one by one. The first one being that we cannot live without carbohydrates. And for this, I want to show this summary of metabolism. I do not have time to go into detail about metabolism, but suffice it to say that this central molecule here, acetyl-CoA, it is a 2-carbon molecule, which is the entry point to the Krebs acid or the citric acid cycle. And you can see that this acetyl-CoA, you can get acetyl-CoA either from pyruvic acid, you can get acetyl-CoA from fat metabolism, or you can get acetyl-CoA from protein metabolism. So even if you cut out carbohydrate totally in the diet, which we cannot do and we will not usually do, you can still get your energy source from fats and you can get it from proteins. So it is a myth to say that we cannot live without carbohydrates. However, most guidelines say take in 100 to 130 grams of carbohydrate per day. Why do we say that? We say that because this is the minimal amount of carbohydrate, so-called minimal amount of carbohydrate needed for brain metabolism. But the brain can also use ketone bodies for its energy source. It cannot use fatty acids because fatty acids cannot cross the blood-brain barrier, but brains can use ketone bodies. So, but the thinking behind saying don't reduce your carbohydrate to less than 130 or 100 grams per day is because this is the amount that is needed for the brain. Certainly, we can live on carbohydrate intake, which is as low as 70 to 100 grams of carbohydrate per day without any problem. The second common misconception is that low carb leads to ketoacidosis. Now, a word about ketone bodies. Remember, I said that acetyl-CoA is a 2-carbon molecule. Ketone body is a 4-carbon molecule. So you can see whether it's beta hydroxybutyrate or acetoacetate or acetoacetyl-CoA, these are all 4-carbon molecules. Normally, our body makes ketone bodies. Normally, we make a little bit of ketone bodies because this is the precursor for cholesterol. We make this as HMG-CoA. How do we make this? The ketone bodies are made from that same 2-carbon molecule, our favorite acetyl-CoA. This acetyl-CoA we get from breaking down fat. So the fat stores are broken down from the adipose tissue, travels in the blood as free fatty acids, and enters the liver, and the liver normally makes ketone bodies. And insulin is a hormone that inhibits the breakdown of this fat. So every time we eat carbohydrate, our body makes insulin and prevents the breakdown of this fat. When we do not eat, or we eat very little carbohydrate and there is no insulin, fat can be broken down. And of course, the other thing is that when we eat, ketone body production is turned off. When we fast, ketone body production is increased because our brain needs ketone body. So when we do not consume carbohydrate, our body very easily turns to burning fat, generating ketone bodies, which can be used for energy. And we need to understand the difference between ketosis and ketoacidosis. Ketosis is elevated ketone bodies in the blood. Normal levels are less than about 0.1 millimoles per liter, not detectable in the blood. When we starve, it'll probably go up to 10 millimoles. But in this, you will have a normal anion gap with no acidosis. In diabetic ketoacidosis, ketone levels can increase up to 70 millimoles and you will have acidosis. So there is a difference between ketosis and ketoacidosis. Ketosis per se is not harmful. Ketoacidosis is definitely life-threatening and harmful. Even very low carbohydrate diet, which again, I want to reiterate, I'm not emphasizing, but even very low carbohydrate diet, when you're consuming less than 20 grams per day, they do develop ketosis. And that is the way they lose weight. That is the way they control their sugar, but they do not develop ketoacidosis unless they have no insulin. So what does that mean? Even a person with type 1 diabetes can maintain a low carbohydrate diet, but they can never come off insulin. So I have patients with type 1 diabetes who try to maintain a low carb diet. They still need to take in their 3 or 4 units of insulin per day to prevent ketoacidosis. But they do not need the 40 or 50 units of insulin a day that they need to control their blood sugars. So in type 1 diabetes, we need to remember that insulin is needed both to reduce hyperglycemia and to prevent ketoacidosis. When you take away the hyperglycemic component, they still need insulin to prevent the ketoacidosis. However, this is not what is seen in people who maintain a low carb diet. First of all, with the diet that we recommend, that is 100 grams a day or 120 grams a day, you cannot go into ketosis. But even when you take a very low carbohydrate diet, unless you have type 1 diabetes, where you have absolutely no insulin on board and you do not take your insulin, even a low carbohydrate diet, you cannot go into ketoacidosis. The third misconception is that it encourages high fat intake. And like I said, in our type of a sample diet, we usually do not recommend a high fat intake. We say do not be afraid of fat, do include some good fats, do include your nuts, do include some peanuts. In our country, that's a very, very cheap source of protein and good fats. Do include your almonds and other types of nuts. And do not be afraid of taking in a little bit of ghee in your diet. So that one roti that you have or the 2 rotis you have do have a little bit of ghee in it. Do not be afraid of fat. That is the way I would encourage fat intake. And it does not cause renal failure. Atkins did not die of renal failure. Just as an aside, Atkins died of, this is like a big misconception. Atkins died after a head injury. He slipped on an icy footpath in New York in the winter, hit his head, got a head injury and died. He did not die of renal failure. However, I'm not advocating the Atkins diet, but just to say that low carbohydrate diets, provided it's a well-balanced diet and you know what we advise appropriately to the patient, certainly it cannot cause renal failure. What do the guidelines say? I want to talk about the ICMR guidelines, which came out in 2020. They come out to their guidelines only once in 10 years. So this was jointly published by ICMR and the NIN, National Institute of Nutrition Guidelines. For the first time, and this is from the paper, for the first time, they have said a minimum intake of 100 to 130 grams a day carbohydrates per day should be ensured for ages 1 year and above. So this is where we say, can we live without carbohydrates? The answer is maybe not. You have to take in at least 100 to 130 grams of carbohydrate a day, but it does not need to be the 400 grams that most of us consume and worsen the diabetes. The American Diabetes Association last year said, carbohydrate intake should emphasize nutrient-dense carbohydrate sources. Reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia. So definitely ADA has said that reduce the carbohydrate intake in the diet, and it can be applied in a variety of eating patterns that meets individual needs and preferences. What is the practical advice that we give to patients? Reduce what you eat by 50%. So for breakfast and dinner, instead of having 4 idlis, have 2 idlis. Even the idlis, and take out the rice and make it just with the pulses. Just have your urad dal and your I don't know what we say in Tamil, we say pasi parapu. Take 50% of this, 50% of that. Make your idlis with that. Fill your plate instead with, if you're still feeling hungry, either have an egg or have lots of nuts. Lunch, keep 8 to 10 cups on your plate. Fill only 1 cup with rice. Remaining 8 to 9 cups, fill it up with your dal and your sabji and your salad and your curd. Fill up everything else. Have only 1 cup of rice. And remember that cereals and millets are exactly the same in terms of carb content. So even when you're having millet rice or jowar roti or ragi roti, the quantity should be less because that is also carbohydrate. And when blood sugars are high, avoid all fruits. Reduce all fruits contain the same amount of carbohydrate. Reintroduce fruits after your sugars have come down and your insulin sensitivity has been re-established. Reintroduce fruit intake to the point where your sugar levels are not starting to go up. Where should we be careful with low carb diets? Like I pointed out in my third case, the sugars start coming down fairly rapidly. So reduce insulin dose, reduce sulfonylurea dose. Make them measure their blood sugars regularly. Type 2 diabetes need to remain on insulin. In general, I do not advise very low carbohydrate diet to the type 1 diabetes. I work with them. I tell them that it can work, but we have to reduce the insulin. You cannot go off insulin. In people with CKD stage 4 or 5, we have to be very careful, obviously, about the protein intake, particularly animal protein intake. In the first few days of reducing carbohydrates, people notice that they feel very tired and they get constipated. After about 2 weeks, they are very fine, and that's something we have to tell them because otherwise they stop it very quickly. And in the first few months of trying a low carb diet, they have to be fairly strict. Then only they'll be able to get these dramatic results that I have seen. Once the insulin sensitivity has been re-established, you get your HbA1c down to 5.5, 5.6, then you can relax it a little bit and see what level of carbohydrate your body is able to tolerate. Some of the other advantages we've seen with maintaining a low carb diet is that, first of all, frustrated patients feel happy. People are just so happy that they see their sugar levels coming down. They think they're doing everything right. They're taking their insulin doses and they just feel so frustrated when the sugar levels, I only eat 2 idlis, doctor, but my sugar is not coming down. When they see that just changing that, they eat eggs if they can, or they have dal idli, they see the difference. They just feel so happy and satisfied. It lessens hypoglycemic episodes. It is associated with weight reduction because you're having less insulin, less of the anabolic hormone. Their GI bloating goes away. For a lot of people, I've realized that the carbohydrate is the one that causes the bloating. So bloating becomes less. Joint pains, aches and pains become less because a large part of that is related to the inflammation related to this insulin resistance. And they actually feel more energetic. One of the main concerns they have when we tell them you have to be eating this amount is, oh, I'm going to feel so tired. I'm already eating so much and I'm feeling tired. You're telling me to eat so little. I'm going to feel even more tired. They actually feel much better. They actually think more clearly. Something called the carbohydrate fog goes away. They feel much better. They prefer to remain on a diet which has lesser carbohydrate in the long term just because they feel so much better. So finally, I want to finish by saying that the efficacy of lowering carbohydrate intake, I think, is well established. The guidelines are also recommending it. And fad diets, so thinking about an LCHF diet or keto diet or Atkins diet, these sort of fad diets should not detract from the utility and hence the usage of low carb diets in our day-to-day practice. I'm going to stop here and thank you very much again, Dr.